Greetings. My name is Princess Sibanda and I'll be presenting on gender dysphoria. Gender dysphoria is the incongruence between a person's physical or assigned gender and the gender with which they identify. Gender is defined by society and usually legally recognized with social and psychological factors that contribute to gender development. Assigned gender refers to a person's assigned sex as male or female at birth. It is based on the anatomy and other visible physical characteristics. Gender dysphoria is a term that refers to an individual's lack of contentment with their gender assigned at birth. The word dysphoria comes from the Greek phrase difficult to bear. Gender dysphoria was added to the DSM in 2013 as a diagnostic category with strict criteria for determining which cases are clinically significant. It took the place of gender identity disorder, a contentious condition that had received a lot of criticism for over-pathologizing the transgender community's life experiences. Gender dysphoria differs from gender identity disorder in that it is more concerned with anxiety than with identity. It does not presume pathology in naturally occurring gender differences. People diagnosed with gender dysphoria are uncomfortable with the gender they were assigned at birth. They may be uncomfortable with the expected roles of their assigned gender. People with such feelings may be affected in various ways. They may change the way they wish to express themselves, especially through gender behavior. The way they dress may be affected by the way they view themselves. Therefore, some people may cross-dress, others may want to sex change through surgery or hormone treatment. For many people, the physical maturation and development of their misaligned secondary sexual features is a source of embarrassment, disgust, and frustration. It is also possible that it will result in mutilation. Gender dysphoria in children according to the DSM-5. Insisting that they are the opposite sex, disliking or unwilling to wear clothes that are normally worn by their sex and prefer to wear clothes normally worn by the opposite sex. Dislikes and refuses to participate in activities and games associated with their sex, preferring to participate in activities and games associated with the opposite sex, also preferring to play with children of the opposite biological sex, disliking to urinate as other members of their biological sex do, in hopes that their genitals will alter. And lastly, experiencing intense distress as a result of puberty's physical adjustments. Any or more of these behaviors may be displayed by children with gender dysphoria. These types of behaviors are common in children and do not generally indicate that your child has gender dysphoria. Many girls exhibit tomboyish behavior, which is commonly expected as a natural part of a female development. It's often not unusual for boys to pretend to be girls and dress up in their mother's or sister's clothes. Again, this is normally just a process. If a teen or an adult has struggled with gender dysphoria since childhood, they might now better understand their gender identity. The effects of gender dysphoria on adults and adolescents vary from those on children. Without a doubt, gender identity is at odds with biological sex. Some people may try to ignore their emotions and live the life of their biological sex without help and support. However, the majority of individuals are unable to maintain this level of activity. It is also difficult to cope with these emotions when they are suppressed. As a result of their gender dysphoria, certain individuals feel depressed, have suicidal thoughts. In these situations, it is important to seek mental health treatment. Gender dysphoria in adults, especially in natal males, has at least two distinct pathways. It is critical to include the characteristics of children because some adults with gender dysphoria will remember a pattern of sex typed activities from their youth that matches their childhood behavior. A significant discrepancy between the child's expressed or experienced gender and the gender assigned at birth must exist for at least 6 months to be diagnosed with gender dysphoria. The desire to be of the opposite gender must be present in children and verbalized. This disorder induces clinically severe distress in vital areas of social, educational, and other functionings. Differential diagnosis. Transvestic fetishism, non-specific gender dysphoria with a consistent congenital intersex condition, and schizophrenia should all be considered in the differential diagnosis. These disorders have a high lifetime psychiatric comorbidity, which should be considered in the assessment and treatment planning of gender dysphoria. Furthermore, a mental health specialist may be consulted whether a patient exhibits signs of borderline personality disorder or is suspected to have the disorder. And lastly, a patient has if a patient has had Asperger's syndrome in the past, when gender dysphoria is diagnosed or assumed, a mental health specialist may be consulted to distinguish actual gender dysphoria from Asperger's syndrome. Etiology. The precise cause of gender dysphoria remains unclear, and the origin of gender dysphoria is still being debated. Gender dysphoria is most likely the product of a combination of causes. Recent research has shown that there could be biological factors involved in the formation of gender before birth. More research needs to be done on the causes of gender dysphoria. Psychiatric and neuropsychology experts believe that gender dysphoria occurs inside the person and are looking for scientific reasons for the recurring sensation of being cast into the wrong body, and how one's gender and orientation and birth assigned sex can become misaligned. Much of the vital gender formation that defines the gender identity occurs in the womb. Hormones responsible for the formation of sex cannot function correctly in extreme circumstances, resulting in the conflict between gender identity and assigned gender. The sex could be male, but the gender could be female. This could be due to an overflow of hormones in the mother's bloodstream or the fetus's sensitivity to hormones. The malfunctioning of hormones in the womb may result in gender dysphoria. Unusual disorders and intersex conditions can also cause gender dysphoria. Prevalence. The majority of people with gender dysphoria remember a childhood onset, and transgender women are more likely than transgender men to undergo care later in life. A study on gender dysphoria in children discovered that the average age for a child to first identify as transgender was 8.3 years old, and that transgender women reported their gender dysphoria at a younger age on average than transgender men. 54.4% of natal males who later identified as transgender first identified feelings of gender dysphoria before the age of 0 to 6 years, versus 38.3% of natal females. Gender dysphoria is usually diagnosed in more natal males than natal females in infants, though this may be attributed in part to stronger parental rejection of gender non-conforming practices in natal boys than in natal girls. Adolescents who had been diagnosed with gender identity disorder, as infants reported that gender dysphoric manifestations started at the age of 6 and worsened with the social and psychological improvements that occurred between the age of 10 and 13. Furthermore, in twin studies, chromosomal, which are identical twins, have much higher prevalence of gender dysphoria than fraternal twins of the same or opposite sex, including the fact that majority of identical twins are still incongruent for gender dysphoria. Intervention strategies are designed to assist individuals with the disorder in living their lives as they wish, regardless of their gender identity. Not everyone who struggles from gender dysphoria will choose to alter their sexuality or gender orientation. Intervention programs are meant to assist them in being content with who they are. A year before having genital reconstructive surgery, one may have to leave with their assigned gender. This is referred to as a social transformation, a real life experience. It will assist in determining if permanent surgery is the best solution. After consulting with a medical practitioner, one can begin the social transformation as soon as they are able to start. The transformation time will last anywhere from 1 to 2 years, depending on the circumstances. For adolescents and younger children, the doctor might refer them and their family to the Child and Adolescent Mental Health Service team or keep an eye on the child's condition on a regular basis. Once a juvenile has been admitted into CAMHS program, the family will apply for the treatment abroad. If an individual is worried about how the family and friends will respond, the doctor might suggest psychotherapy or counseling. It was suggested that in such situations, the child's parents must choose which gender to raise their child. However, it is now considered that waiting until the child is able to select their own gender identity before undergoing surgery to affirm if it is preferable. The use of pronouns that affirm the client's orientation is a significant concern for therapists. People of the transgender community experience a series of ongoing pathologizing and discrimination. Rarely have researchers looked at how these factors can affect trans parents. Early literature also assumed that having a trans parent would cause a damage to the child. The degree to which transgender parents lost touch with their children after coming out as transgender or transitioning has been studied in several research. Neither of these studies looked at the effects of custody and other court rulings, other parents' control, or social judgment in general on transgender parents. Transgender parents face transphobia and virus stressors. This result on practicing mental health providers such as social workers and psychiatrists to assist transgender parents in obtaining psychosocial care, as well as to encourage them to do so. Family members should be supported and transphobic reactions should be minimized. South African context. Although a few healthcare providers assist with gender affirming care, they do this on their own initiative, with too little to no funding from larger structures or agencies. As a result, global and state sanctioned gender affirming care standards are required to expand access. There needs to be commitment to equal gender affirming care in all healthcare facilities. Despite groundbreaking constitutional legislation, the experience of the transgender community in South Africa has most likely been marginalized and silenced by a patriarchal, gender neutral, and prescriptive culture. Logistical issues placed rural patients at an extreme disadvantage. High levels of shame and persecution are all societal stresses that wreak havoc on people's welfare. The, discretion, the discretionary essence of treatment ensures that a transgender person's access to treatment is contingent on their luck in finding systematic and competent healthcare provider.